We'll be starting with today's session. I'll just do a recap first, and then we'll go to the today's talk. We'll finish first yesterday's talk on management, and then we'll go for today's schedules. So, ECMO, we started yesterday with the basics of ECMO. That is, the entire day was on basics of ECMO, and we discussed on. We started with the ECMO introduction and indications of ECMO. Just a minute. Just a minute. We covered a meeting that's good. Yeah. Sorry. So, ECMO is no, it's just a bridge. It's not the solution by itself. So it is a bridge to either recovery, a nurse's device, or a transplant. So whenever you think about ECMO, you have to think that what you are going to bridge to. Always consider ECMO at the stage where the mortality is more than 50%. So by the time ECMO is initiated, uh, probably it will be at the stage of mortality, which is 80%. The reason for considering ECMO or thinking about ECMO early stage, because in that scenario, because you know that it takes time for everything to be organized, family to take decision, they might go for second opinion, and then even once the family is decided, even it will take some logistic time for you to organize and arrange everything. So you should always start thinking about ECMO at early stage, so that when it is actually required, you are ready to initiate ECMO. And if the patient improves during that phase, in that time frame, then definitely you don't require to go for ECMO, then you can always hold it on. So always start thinking of ECMO when the risk of mortality is more than 50%. So start thinking about ECMO or talking about ECMO when the PF ratio is less than 150. And once the PF ratio goes less than 100, you should initiate ECMO. Similarly, in cardiogenic shock also, start thinking about ECMO when the inotropic requirement increases, when the inotropic score is more than 20 and your patient is on dual inotropes. So when you start thinking about patient on the dual inotropes, probably by the time the patient goes on triple inotropes and he requires an IBP and the inotropic score goes more than 40, you can able to initiate ECMO. The most important parameters to decide about ECMO, cardiac ECMO, is the lactate levels. It's the lactate level which is rising trend by say 0.75 to 1 millimole per hour. That itself becomes an indication to go for an ECMO. So don't only think about mean arterial pressure. Patient might hold on mean arterial pressure because of your inotropes or because of your, sympathetic response and vasoconstriction. But what is most important is whether the output is adequate or no, and that can be cardiac output is adequate or no, and that can be decided by the lactate level. So just look at the serial lactates, and if the lactates are rising trend, then you have to think about putting the patient on ECMO. As I told you, remember, bridge to nowhere is not a good idea to put the patient on ECMO. Then that won't be any success. So if the patient is of, say, chronic lung disease or DCM, and then you need to put this patient on ECMO, and you know that the patient is not a candidate for a transplant or assist device, then probably that is not a great idea to put this patient on ECMO. So to assess and choose the ECMO candidate wisely and early, choose mode of ECMO depending on the organ supports needed, and ensure adequate tissue perfusion. Repeatedly, I'm telling you, it is not to delay the inevitable, but it is to give a chance to recover. Then Dr. Pomani talked about the history of ECMO, and he discussed about how the ECMO development took place, different landmark trials, NIS, Scissors trial, Eolia trial. He talked about the ELSO, the different organizations, the ELSO organization, the SWAC ELSO and ECMO Society of India. And he talked about the ELSO statistics also. This is how the ECMO developed in India. Is a roadmap of ECMO, clinical applications of ECMO in India. in 1990s, late 1990s, there was some cases of pediatric cardiac ECMO post-surgical used to be done, that more like an extended CPB. And then in 2006, we started an ECMO program in ICU. And 2008-9, uh, gradually the program shifted only from cardiac ECMO to medical ICU and respiratory ICU, ECMO also. In 2010, we started with a mobile ECMO unit, and we used to go all over India and doing ECMO cases. The first place we visited was Hyderabad. 2012, the transplant program started and road transport was done. 2013, Dr. Vivek Gupta has done a lot of work on cell force positioning, and then he has changed the mortality from almost 100% to nearly 30% or so. And then again, there was an epidemic of H1N1, and in 2014-15, and during that, there are a few more centers developed who started doing ECMO by themselves. And then most of the ECMO boost came in during COVID time, and there were a lot of ECMO centers developed after the COVID time. This is how the academic program is developed in India. The first book was published in 2010, and then we started a training course. We established ECMO Society of India. Then ELSO was originated, and after that, we started with the academic wing of in 2019. We started the fellowship and certificate course from that time. And in 2024, we started with the state branches, pediatric wings, research wings, and Indian College of ECMO. And in 2024, we are going to come up with we have started the research lab, and we are going to come up with the textbook of ECMO, which is multi-author. So this is when I did a survey in February in 2023. This is a response I got from 83 centers, and they have done up to that time 3,500 cases they have done till that time. Most of the center was doing less than 10 cases per year, almost 24%. Only the 8% of the centers were doing more than 30 cases per year. And this was a figure at that time, and there were almost around 950 centers. 950 is the ECMOs we are doing in a year. But remember, this is only 83 centers who has participated, and there are almost around 200 centers doing ECMO in India. So that numbers are much less than what actually. And if you see, most of these ECMO case centers have developed in from the 2020 to 2023. Almost 51% of the centers developed during that time. Then I talked about the physiology of ECMO. How the physiology of ECMO takes place, the circuit-related reactions, that is most important. You should know how your circuit is. So the pump is a centrifugal pump that is preload and afterload dependent, and it traps the air. That is very important. Oxygenator is PMP oxygenator, which is a gold standard, and there's no plasma leak and no wake out. And all circuits can give rise to surge reaction. There is always a dual circulations when you put the person on ECMO. In VA ECMO, the dual circulation is parallel to each other. In VV ECMO, it is in series with each other. And that's why there's a lot of hemodynamic changes when it comes to a VA ECMO, but there are very few hemodynamic changes when it comes to VV ECMO. The problem with VV ECMO is going to be recirculation because both the cannulas are in the vein. And the problem with the VA ECMO is going to be decrease in the preload. So your cardiac stunning and differential hypoxia. Remember, VA ECMO is unphysiological ECMO. It decreases the preload, agreed, but it increases the afterload. Physiology of gas exchange remains same for VA and VV ECMO both. Remember, delivery is always 5 times more than the consumption, and delivery not only depends upon your cardiac output, but on hemoglobin, saturation, and PO2. And consumption is decreased by the rest, decreasing the metabolic activity and hypothermia. And these are the different ways which we utilize in VV ECMO to improve the saturation. Okay. Then there's a talk on types of ECMO, VA, VV, and hybrid ECMO. The important tips for VA ECMO is it is basically a partial flow. Always maintain partial flow in VA ECMO. Never try to go on 100% or full flow on ECMO because, as I told you, VA ECMO is a parallel to each other. So always try to maintain with a partial flow. Maintain pulse pressure of around more than 10 so that cardiac stunning chances are less. always titrate the flow depending upon the tissue perfusion and not depending on the blood, the mean arterial pressure. Always look at the tissue perfusion. So you look at lactates or venous saturation. If that is improving, that means your flow is adequate. If that is not improving, means your flow is not adequate. Never forget to put distal perfusion cannula. Avoid flow directed towards the aortic wall because that will increase the regurgitation and that will damage the aortic wall. Monitor saturation in the right hand just to diagnose differential hypoxia, and if required, you might have to switch over to VAV ECMO to manage the differential hypoxia. Look for the cardiac stunning. Try to avoid cardiac stunning. If the cardiac stunning comes, then that will lead to LV distension, and that can be managed with the first is the medical management, and then if that is not happening, then you have to think about venting the patient either LA vent or LV vent. All this I'm going to discuss in detail tomorrow when I'm going to talk about cardiac stunning and management of cardiac stunning. Most important is give raise to the heart. That is most important in VV ECMO. In VV ECMO, always you maintain the good venous pressure so that you get good flow. Recirculation is going to be there, but try to keep it less than 30%. If there's a lot of recirculation or the flow issues, you might have to switch over to do a dual cannulation for drainage and make it VVV ECMO. Saturation usually we accept on lower side, say 85 to 90 saturation is good enough. Don't try to do too many things to improve the saturation because that itself can be harmful. Control the cardiac output, cool the patient. If oxygenation is not improving, you can cool the patient also. Maintain good hematocrit. Most important is to give raise to the lungs. Then Dr. Rakesh talked about hybrid ECMO, when to consider VA ECMO, when to consider VV ECMO, and when to consider patient for VAV or VVA. So the answer to that is you have to just ask yourself which organs you want to support. Suppose you want to just support heart, just think about VA ECMO. If you want to support lung, just think about VV ECMO. And if you want to support both heart as well as lung, then think about VAV ECMO. It's very simple. Suppose patient is got DCM and ejections of 25%, and he comes with a severe ARDS and he requires mild to moderate inotropic support. This patient is requiring right now the indications for ECMO is only the lungs and not the heart. So in that case, I'll still start the VV ECMO because the heart is 25% ejection since long. So that is not going to make my decision to switch over to VAV ECMO. Similarly, if the patient has got ILD and he develops an acute MI and he comes in a cardiogenic shock, his saturation probably might be low, but then in that case, he requires now support only for the heart. So just think about VA. Okay. And there are different permutations and combinations of VVA and VAV ECMOs, depending on the drainage and the return cannula. There can be a different permutation and combinations, and that will be used to in a different situation. So that I think that already was discussed much in detail by Rakesh yesterday. You can use two drainage either from the femoral and jugular vein, or you can even drain LA for in case of VA ECMO when patient goes into cardiac stunning, or patient with a severe hypoxia and goes into right ventricular failure. In that case, you can switch over to VA or VPA ECMO. Okay, so there are different permutations, combinations that you can use in this space. Then Dipanjan talked about the cannulations, the proper selection of the size and size of the circuit and cannula is essential. See, ECMO is what nothing but then getting a good flow. So for a good flow, you should have a largest possible cannula that should go in. But again, you have to see that it should not be snugly fitting to the your vessels. It has to be there has to be even some space from the side because it is going to be a multi-stage and multi-hole cannulas so that you can have a better drainage from that. And should we use preferably should go for Seldinger or semi-circular techniques so that the risk of bleeding is less. Never get panic and never try to force wire. Even wire can injure your vessels, so be very careful. And remember, these patients are going to be on heparin once you put the patient on ECMO. So always remember, even your needle puncture and your wire puncture can create havoc. So never think that can create needle and wire will not able to damage the patient. Okay. And once the cancer is done, close regular surveillance for infection is essential. Then Dr. Sivas spoke about the initiation of ECMO. You have to always think about, you should prepare yourself the team preparation, the relatives preparation, the circuit preparation, the patient preparation is all is essential. You have to go in a sequences. You should have a checklist, proper checklist. Continuous documentation is very essential. Backup emergency plan should be there, and communication with the family is an essential part. When you initiate ECMO, the parameters you need to set is you need to set. You can start with an ECMO flow of around 20 cc per kg per minute, and you gradually go over the flow over 20 to 30 minutes. The reason is that because if you rapidly go up on the flow, it can give us to cardiac shunting. So to avoid cardiac shunting, you should go gradually. Exceptional is only in case of ECPR where you want to decrease the low flow time, and that's why you don't go gradually on the flow. You go up flow on the flow of around 3 to 3.5 liters immediately to avoid the low flow, to decrease the low flow time. Okay. To keep on increasing the flow till the time you get the targets achieved. So whatever your target is of 90 plus, 95 plus, once that is achieved, till the time you have to keep on increasing the flow. And once that is achieved, try to come down on ventilator settings and try to come down on inotropes. Because your goal is to give rest to the lungs and heart and not just to put the ECMO and increase the saturations. Okay. Swift gas flow, always you have to start with 0.5:1 and we can go up to 1.5:1. Always remember, go slowly on swift gas. And then Dr. Goel talked about ECMO organization. Okay. So this is what we have discussed yesterday. If there are any questions on whatever you